So the list for the UNOS score comes from age, sex, race, Social Security, blood group, acceptable heights and ranges. All this stuff spits out this score. And then when we get that score, then we put all your demographic information into the system. And then you get listed based on what the score is. Now, the good news about UVA, we're the only organ procurement, or the only lung transplant program in this organ procurement, which is LifeNet, which is all of Virginia, and a little tiny sliver of North Carolina. So every lung that gets donated, or a potential donation in Virginia, we get first dibs at. Now, we have to have people on our list that match those lungs, because we can't, of course, take every lung that's offered in Virginia if we don't have a lot of people on our list. But that's why I'm here today, to kind of talk to you guys and let you know that we're out here. So, determining the time on the wait list. This is what the LAS is supposed to do, the lung allocation score. The risk of death versus the likelihood of survival. So the higher your score, the chance of you dying on the list is very high. The lower your score, your survival is pretty high. Again, this is a very complicated algorithm that I can't figure out, and I've looked at it for years. My wife, who's a math teacher, can't figure out. She's like, I don't even know what this means. This is higher math than I've ever learned. But it's a scoring system that works, and it's been adjusted. So it was started in 2005. In 2013, I think they looked at it and said, hey, what's going on? And then they started taking into factors like our CF patients. Our CF patients weren't getting transplanted, and why not? Well, because we know that they may have functional reserve because they're young and their heart isn't in bad shape, and we knew that that was the case, so they weren't getting a higher score. So they took that and they said, hey, look, for CF, if you have this diagnosis, we're going to bump your score by 10. And that's when the CF teams started going, oh, our patients are getting transplanted now, they're not dying on our list. Same thing with IPF and ILDs, if you have a lower score. Now, unfortunately, C.O.P.D doesn't get that, because your chance of surviving 5 years with a lung transplant is almost the same as your chance without a lung transplant. So we kind of have to, that's what that algorithm is there for. So, listing patients, candidates at our center, now this is, I'm only going to speak about UVA here. Candidates at our center are required to be within 3 hours of our transplant center. So, if you live in Moyock, North Carolina, there's no way you can get to UVA in 3 hours. Not unless you take a plane. Because there is no road that's going to get you there, especially rush hour. So, if you live more than 3 hours away, then we require you to relocate closer. Now, some centers require you to do that within 30 minutes. You have to move, be in their area within 30 minutes of their time. So it's one of those big things. Every center is different, so you got to take the good with the bad. We just kind of go with it. Transplant centers may assist patients with arrangements for if they live outside the 3 hours. Now, if you have a certain types of insurance, your insurance may say, we're going to let them live at home in Atlanta. The minute you call them, you call our team, and we'll put them on a helicopter and get them to you within 3 hours. That's your insurance. That sometimes happens if your insurance is available to do that. It's very far and few between which insurances do that. That allows for patients to live further away, but it also kind of gets into kind of logistics. If you're trying to fly in bad weather, you're not going to make it to us. So there's always the kind of plus-minus situation in those areas. Whoa! I think the button's stuck. So while you're on the list for lung transplant, we monitor you. We call you and talk to you a lot, and vice versa. You should be calling and talking to us a lot. We see you in clinic every 4 to 12 weeks. You must notify us if there's a problem. If you get sick, if there's some change in your health status, we need to know. And pulmonary rehab is a must. I need you as strong as you can be when you go in for surgery. And I know pulmonary rehab, sometimes people are like, oh, it's just pain to get there, it's a lot, I don't feel like I'm getting anything out of it. If you're doing it, it's working, okay? That's why we require it. So if you're getting worse, more shortness of breath, increased shortness of breath, increased fear of dying, weight loss. Weight loss is a kind of big thing with us. If you lose 10% of your body mass in a matter of 3 months, that's a problem. That means that your lung disease is getting worse, and we need to kind of address why that's happening. So those are things we want to know about if you're on our list. We want to know, when you're not feeling well, what's going on? What are you doing to make it better? And if you don't have a plan for that, we need to start helping you with that plan. Education, education, education. It starts from the day you get our call. The day we call to do an intake, we start doing education. We send you books, we talk to you on the phone, we ask you a bunch of questions, we'll ask if you have any questions, we come and do these kind of things, we send other people to go talk about lung transplant. It always should start before you ever get into the evaluation phase. So lung transplant education is key. Information booklets, the minute you're referred, we start getting our booklet together and sending it to you. Because there are people that we send booklets to, and they read it, and they're like, no thanks, this isn't for me. Okay, no problem. Let us know if you're interested again. Because of some of the illnesses, and because of requirements and things, education can be tricky, but that's where we kind of have to talk to the patient and figure out what exactly works best for them. Pre-transplant education is about self-care, it's about monitoring, it's about getting us into a way of letting us know what's going on. Support groups, we have a heart-lung transplant support group every fourth Thursday of the month. It's from 11:30 to 1:30 in the afternoon, right?
11:30 to 1.
11:30 to 1. See, I don't get to go on. But it's a great opportunity for people to come and talk to people that have had lung transplants and people that are on our waiting list. So if you ever get the opportunity, you can call the lung transplant office and they can give you more information, or you can talk to me after the presentation. But there's a lot of things that we talk about in those support groups that I find are very, very helpful for patients. Determining the type of surgery, that's kind of up to the surgeons. We tend to like to list everyone for a double lung transplant. Now, does that mean that everybody gets a double lung transplant? No. Sometimes we have to make the decision in surgery to stop and only do one lung. Sometimes we have to do a double lung transplant when we weren't expecting it for one reason or another. So a lot of the time we'll list you for single right, single left, or double. Whatever becomes available organ-wise, we try to go with. That way we can get you the best. But we're going to look for the best organ for you, not just whatever becomes available. Types of transplants, like I said, single, bilateral, double, heart-lung transplant, or living lobar. That's done in kids. You're not going to see that in adults. It's very rarely done anymore anyway. So I'll talk about it because I want you guys to kind of understand the gravity of it. For a living lobar, you need 2 different donors that match you genetically for the blood type as well as the type of antibodies and size that you have, that we can take a section of donor A and donor B and then implant them into the recipient. It's really complicated, it's very dangerous, so we don't do it very often, but it is done here in the United States. That's why I wanted to let you know. If you're an adult and they're talking about a living lobar transplant for you, that means you're really, really sick. And finding donors that are compatible is very, very difficult. So immediate postoperative education. You're going to wake up and you're going to hurt. And then you're going to see me looking at you at 6 in the morning going, hey, wake up. Let's go. It's time to get out of bed. Okay? That's what I do. I get people up, I get them moving, I get them going. And you can ask anyone in that hospital. I'm not afraid to wake you up at 6 in the morning and say, hey guys, in the chair today. Don't care if you're on the ventilator, don't care if you're off of it. I need you up, I need you moving. Because that's how you're going to get the fluid out of your chest. That's how you're going to get blood to drain out. You've got to get you up and moving, and exercise is the key. I have a physical therapist that calls me anytime we have a patient in-house. How long do you want to exercise them today? Let's go an hour, see how they do. The next day, let's do it an hour and a half, see how they do. Now, that's not just the physical therapist, that's what we're going to make you do on top of what physical therapy is working on. Okay? So it can be very, 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 a lot. The big thing with education after surgery is the compliance issue. You're going to be on a lot of medicines. It's going to be multiple times a day for a while. It's hard, you know. I think people sometimes take upwards of 40 pills a day. That's not to include breathing treatments that they might have to do. It's a lot of work. It's a full-time job. So we require people to kind of get with the program, and if you're not compliant, we are going to have to get tough on you. I mean, I'm already tough on you, but you haven't met really tough. So it's one of those things that we require. We also, pulmonary rehab after transplant, it's key. I can't tell you how much pulmonary rehab is helpful. And now, you don't have to go to our pulmonary rehab, but you have to be enrolled in a program after transplant, and that is one of the things. And we talk to all the folks. Chris here at Chippenham, I know her number. I'm not afraid to give her a call and call, hey, Chris, you need to work this person harder. Okay, we need to see better. We need to see them getting better and stronger. Hand washing, surgical masks, that's all stuff that we kind of go through. When you need to wear it, what you need to do to kind of protect yourself. Big thing, when to call the transplant center. You know, the question is when not to. Okay, if there's a problem, if there's an issue, if there's a question, you pick up the phone, you call us. We have someone on call 24 hours a day, 7 days a week to answer questions for lung transplant patients. That person may not be me, but it may be somebody who knows lung transplant, and they're going to be able to pick up the phone and call. You're going to be able to call them. Now, 2 o'clock in the morning is not the time to call and ask, hey, what about this? But, you know, it is the time if you've had a lung transplant and you've got a problem and you're like, hey, what do you think about this? That's when we want you to call that person. Single and most important part of the management is this. Okay? That's the Incentivespirometer. People think I'm joking. If I come into clinic room 2 weeks after your surgery and say, how are you getting your Incentivespirometer? Well, I'm like, you're not doing it enough. If you say, well, I don't know where it is, I get you a new one. It's not a problem. I got hundreds of them. They're like sitting in my office in boxes. So the challenge. With lung transplant especially, the vast majority of the organs that are coming from donors, these patients have had a brain death event. So they've either had a bleed or something that's caused them to become brain dead. That's not good for the lungs. When your body becomes brain dead, it really hurts the lungs. It treats the lungs as if there's something wrong with them. So only 15 to 20% of the lungs that are offered out are transplanted. That's a really low number. I mean, 15%, it's hardly anything. The other part is so, you know, and this data is a couple of years old now. I mean, 120,000 on the waiting list. You know, now this isn't just lungs, this is all. I mean, but we are only doing 28,000, almost 29,000 transplants a year in the United States. That's a drop in the bucket. So that's all organs, not just lungs. So timing a referral is early. The earlier, and remember, your physician doesn't have to refer you. Okay? That's kind of a myth, that you have to have your doctor's approval to be referred for lung transplant. That's not the case. We have to talk to your doctor because we need to get the information from them. But we also know that, you know, people are informed consumers, and if you're looking out for yourself, you should be kind of referring yourself. Patient education is key as well. So factors affecting wait time. Now, wait times are really crazy because some people are on our list for years and some people are on our list for minutes. And we have literally talked about someone in the selection committee, went into the office, got everything put into UNOS, and then 5 minutes later, they're calling us saying, hey, we have this organ for this person. It just happens to how sick they are, you know, what's going on, what donor was available, what the donor size was, what their blood type was, what the organ was all about. It really depends. Unfortunately, this is our Achilles heel. So we have a great 1 to 2 year survival rate in lung transplant. And it's been like this for 15 years. The unfortunate part is that as the years go out, 3, 4, 5 years, the survival rate declines. And one of those things with lung transplant across the board from ISHLT is that a lot of people, once they get past the 2nd year, it's not anything to do with the lung transplant that they die from. It's other things. It's the cancer, it's heart disease, it's car accidents. It's just unfortunate that all that affects the statistical ways of lung transplant. Yes?
Is it from the med?
It's some of the reasons they die.